Back taking your phone calls as we discuss diabetes on this Monday night. Want to keep taking your calls. Let's get right to Linda. Hey, Linda, welcome.
Hi.
Thanks for holding.
I have a brother that was diagnosed 2 years ago with diabetes, diabetic ketoacidosis. And I was wondering, once you have it, do you always have that?
Oh, good question.
Yeah.
What is that?
So ketoacidosis refers to a complication that we almost always see with type 1 diabetes. So type 1, just to refresh, is the condition where the beta cell, which is this specialized cell in the pancreas that makes insulin, is destroyed. It happens in an unpredictable or mostly unpredictable manner, and it's sudden, it's dramatic, and then there's a need for insulin really for the rest of your life. So that is one of the areas that there's been some progress in terms of trying to reverse that with things like pancreatic transplantation. It hasn't really hit mainstream, and there's been some success and some not so much success. It's been a difficult process and procedure for us to do on a small basis, and even certainly to scale it to the rest of the population. But I think if it was ketoacidosis, that is most often accompanied, we most often see that with type 1 diabetes, and that is permanent. Yeah.
It is.
Yeah.
Okay. Linda, did you get that?
Yes, I did.
It is. Okay. Is that someone you know, or yourself?
Yes, that's my brother that was diagnosed with that, and he was like about 41, 42 when he was diagnosed with that.
Pretty young.
That is young, and occasionally, Linda, we see ketoacidosis in folks that have type 2 diabetes in certain ethnic groups, but most often it's in type 1. Linda, I want to give you a little bit of hope that the management of type 1 diabetes today, if he were to come see me in clinic, couldn't be more different than when I was a house officer. If you will, the gadgets and gizmos are more sophisticated, as well as the insulin products that we have. We haven't made progress to the point of cure, but we've made a lot of progress in care. I think we care a lot better because of some of the advances, and we're actively looking for ways to reverse these things, but it's been tricky to reverse.
Let's continue on. Johnny is up next. Hey, Johnny. Johnny, you there?
Yeah.
Hey, go ahead. What's on your mind?
Well, he answered my question already. I was going to ask about transplanting.
Transplant, yeah.
Put a bad pancreas be transplanted with a good one.
Okay. Hold on. Let's hear what the doctor has to say about it. You mentioned that there's a little bit of
transplant is tricky. I mean, there's the part of the problem is the pancreas itself is an incredibly difficult organ for multiple reasons. It's very, very different than transplanting a kidney, which is probably the one that we do the most, or even a liver, which is really quite complex. Transplanting a pancreas for multiple reasons is really quite difficult. And oftentimes what happens is you leave the old pancreas in, at least large parts, and you implant parts that have the beta cell in it. Because the pancreas does other things, including release a number of enzymes that assist in digestion. So you don't want to take out that part. So what you wind up doing is overlaying an artificial piece, hoping that that takes, and then it produces the insulin that you would need. Unfortunately, like all transplants, there is a number of medications that we have to give. We call them immunosuppressives, and what the medications do is they suppress your immune system. Right. And that can be difficult, and it's not straightforward. And I will just say that there have been some success. It has not been as dramatic as we wish it would be in the medical community.
Wanted to ask you, while we're talking about the pancreas, we hear a lot about pancreatic cancer. Is there any connection, or is this just an organ that is affected? The cancer maybe derives in another organ and metastasizes to the pancreas, and it's one of those that by the time we hear so much that, by the time it's diagnosed, it's often just too late.
Yeah, pancreatic cancer is one of the sadder conditions that I see. it really is one of the deadlier diseases that we encounter in medicine.
And it is because by the time some of the symptoms show up, it has advanced so far?
So that's part of it. The other part is that we haven't found chemotherapies that have been particularly effective. Surgical interventions have not been particularly effective. Occasionally you'll catch someone in stage 1. Sometimes sort of you found it by accident as part of a CT or something like that, and you can remove stuff. Oftentimes you're quite right to point out that it's diagnosed at later stages. I wouldn't put too much of a link between pancreatic cancer and diabetes. I would sort of think of them as true unrelated. But pancreatic cancer is an extremely aggressive and very difficult diagnosis.
All right, 737 plus if you'd like to call in. Let's go to Jane on line 1. Hi, Jane.
Hello.
Hi, Jane. Go ahead.
Hi. I'm also a diabetic, and it's been about 3 years. And I have a question about the insulin. You see some people that gain weight, and a lot of people lose.
Okay.
And my question is the insulin, when you're insulin, have to be on insulin?
Okay.
Yeah, it can happen. I think if the insulin is delivered inelegantly, and there can be some weight gain. Weight gain, if you're terribly out of control, let's say your sugars are in the 300s or 400s, really high. In fact, it's very hard for us to get you under control without a little bit of weight gain, just because oftentimes when sugars are that high, you're peeing out glucose. In fact, one of the symptoms of diabetes is that you urinate a lot. And part of the reason that you urinate a lot is because sugar is being peed out. Well, if I give you any medication for that matter, whether insulin or something else, and you stop peeing sugar, well, it's going to go somewhere. It's going to go in your body. So it's not uncommon for people to gain a little bit of weight if their sugars are very high. But usually whatever weight gain happens early, and it stabilizes and people don't continue to gain weight. And with the newer insulins, we see a lot less of that. I think the other reason, Rory, you mentioned when people get hypoglycemic and the need to eat. Well, if we have newer insulins where the consequence of the care is less hypoglycemia, then they're less likely to eat a lot. So I would say that today with the newer insulin products, you can achieve pretty good glucose control with minimal weight gain.
I want to talk a little bit about diet with you and how important, as we've touched on it, and weight gain and sugars and all of the above, and just how really what we eat can make such a big difference in whether or not you get diabetes, and also the treatment of it, of keeping it under control. I know you're also, we talked about the research you do. It's called GRADE, the Glycemic Reduction Approaches in Diabetes, a Comparative Effectiveness Study at the Vanderbilt Center for Diabetes Translation Research. There's a lot there to go through. But I'm fascinated with the whole glycemic index and these foods that can spike your blood sugar much quicker than other foods that maybe have a steadier approach. And we've heard a lot about good carbs, bad carbs, and a lot about sugar in the last couple of years. There's been a push to really start reading labels and realizing how much sugar we are taking in.
So it's a large space. It's a large area to talk about that. Let me make a couple of comments.
Sure.
The noun is probably more important than the adjective.
Okay.
So the word diet, as opposed to the type of diet, low carb, low fat. So the calories are just as important as the carbohydrates, if not more so, especially for the development of diabetes. So for the development of diabetes, if your weight is normal and you're consuming an appropriate amount of calorie for your body size, then the nature of the calories don't seem to matter quite as much. That's if you don't have diabetes. Once you develop diabetes, then the type of calories matter more.
Gotcha.
Quite a bit more.
Yeah, that makes sense.
Quite a bit more. And if I eat something, but it's so nuanced and so rich, the literature on this, I'm always stunned when the reaction I get when I talk to colleagues and I say, if I take the same pasta and cook it for X minutes versus cooking it for 5 more minutes,
right,
I get a different surge in terms of the glucose. So it's such a rich area, and this is where having a dietitian that can work with you can be so helpful and so informative, in particular for folks that have diabetes, where I really do think the content of the diet is so important. I think for folks that have that are worried about developing diabetes, I think the key word is diet. Eat well. Eat healthy and don't eat too much.
Moderation.
In moderation. And I think whether you choose to lose weight versus this approach or that approach, whatever works for you is fine. Again, the key word is diet. Once you develop diabetes, it's a different story. And I think as it relates to our study, thank you for my plug.
Yeah, sure.
The GRADE study, that one is a really neat study because for individuals who may be interested, we're actually comparing different approaches to reducing glucose in individuals with diabetes. And if for whatever reason any of your audience would be interested, they can just contact us at GRADE, G-R-A-D-E, at vanderbilt.edu, and we'd be happy to tell them a little bit more about different approaches that we're employing. And what we're doing here is we're comparing different approaches. A lot of it is sort of medication approaches to individuals that have diabetes. And it's a wonderful way for us to better understand who benefits more from what. One of your colleagues, several colleagues have mentioned about genetic risk. One of the things that we really focus on at Vanderbilt is trying to tailor a therapy to the attributes of the individual. Not everyone's the same. So one of the things that we're hoping to understand from this study is we know that some of the approaches work, but we don't know for whom what works best. So that's one of the things that we're trying to do as part of that.
It's fascinating stuff, isn't it?
Well, I so appreciate the chance to talk about it. I get really excited talking about it. That's what I do for a living.
No, but it really is interesting to see so much that we don't know yet that we're figuring out, like you said, just about the pasta, what it does to the pasta and how the effect,
when you eat,
I mean,
if you cook, seriously, if you cook that pasta an extra 3 to 4 minutes, you'll have a different surge in your glucose. And the people
this is why I like my pasta al dente a little bit. See, there's a reason I knew, right?
And if you have type 1 diabetes, you're very attuned to these things because folks with type 1 will notice these differences very quickly.
The whole wheat pastas aren't bad. They're not bad. But then we get into the whole gluten sensitivity, and I don't even want to go there. We got to take a break, everybody. We got a couple more phone calls. When we come back, we'll be right back.